Good morning, everybody. Today, our guest speaker is Dr. Priyanka Chavan from Lucknow. He will be lecturing on recent advances in mechanism and treatment of immune thrombocytopenia. This webinar is brought to you by Mumbai Hematology Group, supported by INTAS and managed by Perfect Square. I thank Dr. Manoj Kumar and team INTAS, Mr. Yash, Mr. Kalpesh, and the team Perfect Square, Executive Committee of Mumbai Hematology Group. Our chief guest today, Professor Dr. R.K. Jena from Cuttack. Our guest speaker, Professor Priyanka Chavan from Lucknow. All our discussants who are themselves eminent hematologists from India, Bangladesh, and Singapore. And you participants for sparing your Sunday morning. Let me introduce you to the webinars next weekend. Saturday, 26th of August from 7 p.m. IST onwards. We have Dr. Spiro Catalan from USA speaking to us on atypical hemolytic uremic syndrome. Next day morning, Sunday, 27th of August, 11:30 a.m. IST, we have our own Professor Maitri Bhattacharya from Kolkata speaking to us on an approach to bleeding disorder. Before I proceed further, let me remind you about the midterm conference of Mumbai Hematology Group, which is towards the end of September. And all of you must have received all the details, and the details are also displayed at the website of Mumbai Hematology Group. Discussants today include very important persons who have been put up alphabetically over here. We have Dr. Aditi Shah from Department of Hematology, KM Hospital, Mumbai. Dr. Amreen Pandrowala from BJ Wadia Hospital for Children, Parel, Mumbai. Dr. Amit Jain from Pediatric Hemato-Oncology and BMT Center at Borivali, Mumbai. Dr. Amit Khurana from Akanksha Hematology Center, Surat. Dr. Anju Bharti from Institute of Medical Sciences of BHU, Varanasi. Dr. Arun V.A. from INHS Aswini, Mumbai. Dr. Asha Shah from Nanavati Hospital, Mumbai. Dr. Arshaful Haq from Dhaka Medical College Hospital, Dhaka. Dr. Dheeraj Bhattad from Sir H.N. Reliance Foundation Hospital, Mumbai. Dr. Deepanjan Halder from Jupiter Hospital, Mumbai. Dr. Hamza Dalal from Fortis Hospital, Mumbai. Dr. Nikhil Kumar from AIMS, Delhi. Dr. Parth Ganatra from Wadia Hospital for Children, Mumbai. Dr. Rajesh Patil from HemoCare Hematology Center and Bethany Hospital, Mumbai. Dr. Rita Singh Saxena from Gandhi Medical College and Hamidia Hospital, Bhopal. Dr. Subhash Chandra Jha from NGRS Hospital, Patna. Dr. Swati Kanakia from Lilavati Hospital, Mumbai. Dr. Vishnu Prasad from Department of Lab Medicine, Hu Tech Food Hospital, Singapore. And now it's time to introduce our guest speaker, Dr. Priyanka Chavan, Lucknow. She is consultant hematologist and bone marrow transplant physician at Apollo Medic Super Specialty Hospital, Lucknow. She did her MD in pediatrics, followed by postdoctoral certification course in hemato-oncology and postdoctoral fellowship in BMT from SGPGI. She is EBMT certified. She's ex-assistant professor from the Department of Hematology, SGPGI, Lucknow, and her areas of interest include hematopoietic stem cell transplant, benign or the classical hematology, and the pediatric hematology. She will be lecturing on recent advances in the mechanism and treatment of ITP. And now the most important part of the day, introduction of our chief guest of the day, none other than Professor R.K. Jena from Cuttack, and I'm indeed grateful to him for sparing his time when he is busy with an extremely important conference. He is MD, PhD, hematology. He is hematologist, hemato-oncologist, and BMT physician. He is professor and head department of clinical hematology at the prestigious SCB Medical College and Hospital in Cuttack. He did his MBBS from same institute, followed in 1983, followed by post-graduation in general medicine from VIMSAR Burla. He returned back to SCB Medical College and did his PhD in clinical hematology, which he completed in 2001. And currently, he is professor and head over there. He is a fellow of ISHBT. He has received advanced training in the management of thalassemia from Cyprus, courtesy TIFF, and the bone marrow transplantation from University of Minnesota under VTP program by ASH. He was instrumental in establishing the BMT unit in the Department of Clinical Hematology at SCB Medical College and Hospital. He has over 50 peer-reviewed papers published in international and national journals. He has received the Best Research Paper Award in the annual conference of API 2001, second Best Research Paper Award in the National Conference of POCON 2000, Kolkata, Professor M.C. Mishra Memorial Award of IMA for Best Research Article 1995, and Professor M.C. Mishra Memorial Award of IMA for the Best Case Report 1996. He was a member of various policy formulating agencies like the National Cancer Guidelines 2019 for formulation of protocol for adult hematolymphoid malignancies, NHM Guidelines 2016 for hemoglobinopathy, Ministry of Health, Government of India, Committee for Preparation of Guidelines for Hemophilia by Ministry of Health, Blood Cell, NHM Division, Government of India, and the committee member for Blood Task Force, NHM, Government of Odisha. He is a member of ASH, ISHBT, FOCON, ICON, IPI, and IMA. He was the president ISHBT for the year 2019-20. I request him to inaugurate our today's webinar and give some words of wisdom for our junior colleagues and as well as for all of us. Thank you so much. And over to him.
Thank you, sir, and respected Professor Agrawal and members of the Mumbai Hematology Group, and dear faculties and delegates and the representative of the intense oncology. It's a great honor and I am humbled to get this wonderful opportunity to inaugurate this symposium, which is based on immune-mediated thrombocytopenia. As you know, if you look at the journey of hematology in India since 20 years, hematology was the infancy stage. Even there are many states, it was not a hard subject. Many people, many doctors, they didn't know what is hematology and what is that, how it is there, in which discipline it belongs to, like that. That was the scenario 20 years back across the country. But that, because of the many reasons, even if the incidents, the progress, the changes which has occurred so fast, so there was urgent need in our country to develop the field of hematology in our country. So if you look at, there are many reasons for that. Many institutions were involved in patronizing hematology across the country. To me, I have no hesitation to tell Mumbai Hematology Group is the #1 institution who is the pioneer and really inspired thousands of the people across the country to take up the hematology as career. They popularize hematology, instrumental opening hematology even across the country. Even when I was a student, I attended the fourth, I remember, I attended the fourth CME hematology update organized by the Mumbai Hematology Group by M.B. Agrawal. I was inspired to take up the hematology. So Mumbai, and it is continuing also. If you look at the work and the responsibility carried out by Mumbai Hematology Group, phenomenal. It is really, and it gives a lot of inspiration to people. Instead, it has still increased, even also during COVID time, recent time also. Every weekend, every month, you will find that hematological activity is there by the Mumbai Hematology Group. Every component of the hematology is being taken up, and every faculties, every people across the country is being taken up. Great job done. I congratulate you, sir. My best wishes that please keep it up, this noble work, so that our country will be benefited. With this, I deeply appreciate, give you my sincere thanks to giving me this wonderful opportunity to inaugurate this CME, everything on immune-mediated thrombocytopenia purpura. I wish a great success of this event, sir. Thank you very much, sir. Sir, over to you, sir, now.
Thank you, Professor Jaina. You have been extremely kind for those very, very nice words about MHG. And you also spared your very, very valuable time pulling out yourself from the very important conference that you are organizing and are a part of it. Thank you so much. And now let's come to Dr. Priyanka Chauhan. Dr. Priyanka, it's all your day today. Thank you very much for offering your availability to speak to us on this very, very important subject of ITP, which is not only common, but is also very intriguing from the angle of diagnosis and treatment, and of course, the advances that have occurred in mechanism, which we are going to learn from you today. So over to you, Dr. Priyanka.
Thank you so much, sir. At the outset, I would like to thank you and the Mumbai Hematology Group for giving me this opportunity and this platform where I myself have learned a lot of hematology. I thank you, Professor R.K. Jina, sir, for those words of wisdom. So, without delaying further, I would just like to share my screen. So the topic that we will be discussing today is recent advances in the mechanism and treatment of immune thrombocytopenia.
Priyanka, can you put it to the slideshow mode?
Yeah, sure, sir. Is it okay now, sir?
Yes, perfect.
As hematologists, I think apart from anemia, the most number of cases that we all encounter is of thrombocytopenia. And a major chunk of those thrombocytopenias is immune-mediated thrombocytopenias. Though the management in almost 80% of the cases is simple and they respond to first or a few second line treatment options, but in almost 15 to 20% who are refractory to multiple modes of therapy or relapse after an initial response, they become a nightmare to manage. So my talk today will be focused on these 15 to 20% of the patients who are either refractory or relapse after an initial response. So once a patient of thrombocytopenia comes to us, we have this algorithm in our minds that whether it is a destructive mechanism or it is a mechanism of decreased production or it is a splenic sequestration. And once we have in our mind that it is increased destruction, so we again classify whether it is immune mediated or non-immune mediated. A major chunk of these thrombocytopenic patients can be diagnosed just based on simple history examination and a simple CBC and peripheral smear examination. And we can label them as immune thrombocytopenia. Now, the incidence of immune thrombocytopenia is reported to be 1 to 6.4 per 100,000 population in children and 3.3 to 3.9 per 100,000 population adult per year in the Western literature. Out of these, newly diagnosed cases comprise around 70% and relapsed or refractory patients comprise around 20 to 30%. Looking at the history, it dates back to 11th to 17th century when several case reports of thrombocytopenic purpura were reported. But the first typical case of ITP was reported in 1735 by Paul Verloff. And since then, the expansion of knowledge over the last 100 years have led to the discovery of novel treatment options for the treatment of ITP. The first major breakthrough in the biology of ITP was made in 1950 by the famous Harrington-Hollingsworth experiment that we all are aware of, where Dr. Harrington and 8 of his colleagues injected themselves with the plasma of a lady who was suffering from immune thrombocytopenia. And what they saw was that the platelet count started decreasing within a matter of few hours, and they regained their normal platelet count after 4 to 5 days. So then it was discovered that there is an antiplatelet factor in the plasma that leads to the destruction of platelets in immune thrombocytopenia. Since then, there have been many therapeutic options, right from rituximab to TPO receptor agonists, and now SYK inhibitors and BTK inhibitors as a mechanism to treat these immune thrombocytopenia cases. But the splenectomy, that was the first treatment option available, and the first splenectomy was performed in 1920s, still stands the test of time and remains a major therapeutic modality even in this era. I'll begin this with a case that I recently encountered. She was a 58-year-old female patient. She had a history of petechiae and black tarry stools for 7 days. There was no other history suggestive of any chronic disorder like fever, jaundice, photosensitivity, oral ulcers, dry mouth, any new medications. It was all absent. So she was comorbid. She had hypertension, type 2 diabetes, and hypothyroidism for the last 8 years. On examination, there was pallor, petechiae, and ecchymosis. There was subconjunctival hemorrhage, but rest of the examination was unremarkable. So she was evaluated outside also before coming to our hospital, and the CBC showed just thrombocytopenia with the normal peripheral smear, no atypical cells. Bone marrow was also performed outside only, and it was suggestive of megakaryocytic thrombocytopenia. We did a CBC and a peripheral examination, viral markers at our center, and we diagnosed her as ITP, and we started her on therapy. So prior to coming to our center, she had already received prednisolone at 1 mg per kg for almost 4 days, and 1 dose of romiplastim was also administered. At our center, we started her on IVIG at 1 gram per kg for 2 days. Corticosteroids and romiplastim were continued. But even after 7 days of this therapy, she did not show any response. Then to reconfirm the diagnosis, we re-evaluated her. We repeated a bone marrow aspiration and biopsy, and we sent a karyotype to rule out MDS, which was again megakaryocytic thrombocytopenia and a normal karyotype. We did a DCT, ICT, LDH analysis to rule out Evans syndrome, which was also negative. We again did a CMV PCR that also showed negative results, but her ANA profile showed 3+ positivity, although the dsDNA and ENA were negative. So then in 500 mg BD, but there was no response after 7 days of that also. Then we changed the prednisolone to IV dexapulses. Danazol was added, but no response again. We gave, in view of her comorbid status, her age, and bleeding manifestations, we gave rituximab early on day 11 and just waited for the response. But again, there was no response. At day 18, she became drowsy. She developed pinpoint cerebral hemorrhages. We got an emergency lap splenectomy done on day 18, but after that also there was no response. There was no increase in the platelet count. On day 20, the patient deteriorated. On imaging, there was a thalamic bleed. She was intubated, ventilated, and on day 21, she succumbed to the illness. During the entire course, we gave multiple packed RBC and SDP transfusions as well. So this case led me to think that what else could have been done in this patient. So if we see the overall mortality in newly diagnosed cases, it is just 1 to 2%, and it is because of fatal bleeding. But in mortality in refractory ITP cases can increase up to 40 to 50%. And in them, 50% of this mortality is due to fatal bleeding, but 50% is due to infections because of the various immunosuppressive drugs that are being used for the treatment. If we see the pathogenesis in immune thrombocytopenia, and if we reconsider evaluation in these refractory patients, it was seen in various studies that almost 50% could land up having a different diagnosis. So primary ITP remains the diagnosis in 50%, but the other 50% can have a diagnosis of secondary ITP or inherited thrombocytopenias, bone marrow failures, MDS, and it could be drug-induced ITP. So though secondary ITP in pediatric patient ranges only up to 2% of cases, but in adults, it can go up to 40% of cases being secondary ITP. And these secondary ITP cases are more refractory to the usual therapy of primary ITP. So amongst the secondary etiologies, there could be autoimmune disorders, there could be chronic infections, H. pylori infection, the primary immunodeficiency disorders, malignancies including lymphomas, and they could be drug-induced. So that is why we revisited the diagnosis in our case. And apart from ANA positivity, we did not find any other etiology that could suffice the diagnosis. To investigate these cases, both the American Society of Hematology and the British Society of Hematology have laid down guidelines, and the basic evaluation that has been included in the initial investigation of these ITP cases is history, family history, physical examination, complete blood count with peripheral blood smear, the blood group, and the HIV, HCV, and HBV viral etiologies. But it is seen in various studies, especially in China. There was a review article that was published recently that they showed that 20% of the cases may be misdiagnosed by just doing this basic evaluation. So these patients included patients of MDS, aplastic anemia, secondary ITP, systemic autoimmune disorders leading to thrombocytopenia, some malignancies, and primary immune diseases, and also drug-induced cases. So what else can be done to have a clear-cut diagnosis, have a correct diagnosis of these cases? In China, they have included bone marrow examination in the initial diagnosis of all patients of ITP. There are certain tests that are coming up as tests of potential utility in the management of ITP patients. The first one is the glycoprotein specific antibody assays. Although these assays are quite specific for ITP, but the sensitivity is low. And so if they come out to be positive, we can safely say that the patient has ITP. But if they are negative, we cannot rule out that it is not ITP. Two tests that I consider upfront in my patients who come with thrombocytopenia and are suspected to have immune-mediated thrombocytopenia is the anti-nuclear antibody test and the H. pylori testing in patients who present with some GI manifestations. Because ANA positivity is seen in 15 to 30% of the cases of primary ITP, and they might not have any evidence of any autoimmune disorder at presentation. And they might later, years later, develop SLE or other autoimmune disorders. And these patients are refractory to multiple lines of therapy. Also, H. pylori is quite prevalent in India. And just by eradication of the H. pylori by giving the combination therapy, the ITP patients respond to these agents. Other tests that are of unproven or uncertain benefit are the TPO levels, the immature platelet function, the bleeding time, and the serum complement assays. So the definitions of ITP have also changed over a period of time. During the Vicenza Consensus Conference in October 2007, the terminology that we were using for decades, idiopathic thrombocytopenic purpura, was changed to immune thrombocytopenia primary, because now it is quite evident that the etiology of thrombocytopenia in ITP is not idiopathic. It is immune mediated, and it can be primary or secondary. Then acute and chronic ITP definitions were changed to newly diagnosed, persistent, and chronic. And I think we all are aware of them. Now coming to the pathophysiological mechanisms in ITP. The research over the years have shown that ITP is not a simple disorder. It is a syndrome of complex immunological dysfunction that begins way before the development of thrombocytopenia. So the people having ITP are predisposed. There are certain genetic factors that might be the polymorphisms in various cytokines, in the FC receptors, or other gene polymorphism in the platelet antigens or the HLA that predisposes these individuals to the initial event. The initial event could be an infection, an inflammation that might lead to either a molecular mimicry between the platelet antigens and the pathogen proteins, or it can lead to exposition of the cryptic antigens on the platelet surface, which leads to immune reactivity. The immune system shifts, the balance shifts towards the pro-inflammatory immune system, and this leads to destruction of platelets in these individuals. Several primary immunodeficiency disorders are known to have ITP several-fold higher in their disease course, like CVID, ABS, hyper IgM syndrome. Also, certain chronic infections that we already know, hepatitis B, hepatitis C, HIV, H. pylori, are known to have ITP as their presentation. And autoimmune disorders, of course, can have secondary immune thrombocytopenia. So I have tried to simplify the mechanisms of the pathogenesis of ITP in this cartoon. So if we see, we can basically divide the pathophysiology in immune thrombocytopenia into two: the peripheral destruction mechanisms and the decreased bone marrow production. So once the epitopes on the platelets, the antigens on the platelets are exposed, autoantibodies are generated. First, these antigens are presented by the antigen presenting cells, the macrophages or the dendritic cells, to stimulate the autoreactive T cells, which in turn stimulate the T follicular helper phenotype and They stimulate the autoreactive B cells and the plasma cells to produce antiplatelet antibodies. Once these antiplatelet antibodies are produced, they coat or opsonize the platelets with antigen antibody complexes, and these platelets can be recognized by the macrophage system in the spleen, and they can cause platelet lysis. Second mechanism is by classical complement pathway. There is activation of complement pathway also in ITP, and with deposition of C3, C3b, and C3-9, these opsonized platelets can either undergo phagocytosis by macrophages, or they can undergo intravascular lysis. The third pathway that has been found recently is the destruction in the liver. The antiplatelet antibodies are coated on the platelet surface, which leads to decellulization of these platelet molecules, and they are recognized by the Ashwell-Morel receptors in the liver and leading to their destruction by the hepatocytes. The mechanism of cytotoxic T cell mediated lysis predominates in cases where the antibody production is not found, and cytotoxic T cells can directly lyse these platelets who display abnormal antigens on their surface. Also, these cytotoxic T cells can lead to apoptosis of the megakaryocytes in the bone marrow, leading to decreased proplatelet formation by these megakaryocytes, and decreased TPO production is another mechanism that leads to thrombocytopenia in ITP. Now we will discuss each of these mechanisms one by one. So what is the effect of autoantibodies? Autoantibodies have been found in almost 85% cases of ITP. The major autoantibody that is present is IgG1, which is present in 77%, although rarely IgM or IgA can be present. If we see the particular antibodies, GP2B38 predominates, after which GP1B9 is present, and other autoantibodies, GP1A, 2A, and 4 and 5, are present in small percentage of cases. So the modified monoclonal antibody immobilization of platelet antigen assay that I discussed in the investigations as well is an important method to detect these antibodies. And though it lacks sensitivity, it can be fairly specific to differentiate cases of ITP from aplastic anemia, from hematological malignancies, and from healthy controls. Also, if these antibodies are present or absent, we can direct therapy also based on that I'll be discussing later. So once these autoantibodies opsonize the platelets, they are recognized by the Fc receptor monocytic phagocytic system in the liver and spleen, and this leads to the destruction of these platelets. Second is the effect of autoantibodies on megakaryocytes. So megakaryocytes during their early stages also express GP2B and GP9 glycoproteins on their surface, and autoantibodies can bind to these antigens on the megakaryocytes and then suppress the megakaryocyte proliferation. Also, once the megakaryocyte surface is bounded by these antiplatelet antibodies, they decrease the formation of proplatelets from the megakaryocytes, resulting in decreased platelet production. Second main component of the phagocytic system is the FCY receptors and the reticular endothelial system. So in ITP, various researchers, various murine models have shown that in ITP, there is a shift towards activating FC receptors, leading to propensity of FC receptor mediated clearance of these antibody and antigen complexes. The activating FC receptors are FCR1, FCR2A, and FCR3, whereas the inhibitory receptors are FCR2B. FCR2B is also coming up as a novel biomarker for ITP analysis because the levels are quite low in ITP patients. This FC receptor mediated destruction of platelets have been targeted in therapeutics by the recently discovered anti-FcRn antibody molecules. The two of them, roxanolixizumab and efgartigimod, I will be discussing, and they have entered the phase 3 trials for patients of chronic ITP. Next is the role of antigen presenting cells. So they play a major role in presentation of these cryptic antigens that are exposed on the platelet surface. The antigen presenting cells recognize, bind to, and internalize these protein antigens. The endosomal proteolytic degradation occurs, and they are complex with MHC molecules and are presented to the T cells. Now, there are co-stimulatory signals between antigen presenting cells and the T cells, CD28B7 and CD8086 interactions. This leads to T cell activation, which in turn increases the B cell proliferation and the plasma cell proliferation, and in turn increase secretion of these antibodies. There are two types of antigen presenting cells: the myeloid dendritic cells that activate the cytotoxic T cells and differentiate naive CD4 T cells into Th1, or plasmacytoid dendritic cells that have immunosuppressive properties. So it has been seen that in ITP, the shift is towards the myeloid dendritic cells, that is the activating dendritic cells, and the plasmacytoid dendritic cells are decreased. The next is the T cell phenotypes in ITP. So in the recent years, it has been found that ITP is not only the biology of ITP does not revolve only around B cells and plasma cells. T cells play a major role in ITP phenotypes. So the balance shift towards immune activation, increased Th1 T cells, increased Th17 T cells, and decrease of Th2 phenotype is seen in ITP cases. The T regulatory cells are decreased, therefore the immune tolerance is decreased. These CD16 positive monocyte subset secretes IL-12, which leads to this activation of the Th1 phenotype in ITP, and which in turn is pro-inflammatory, cell-mediated lysis, and complement fixing phenotypes. So Han et al. Evolved this role of this T regulatory and the pro-inflammatory T cell phenotypes in ITP. They use low-dose decitabine and low-dose chidamide, which is an HDAC inhibitor, in ITP patients. And they saw that a low-dose decitabine rebalanced the T regulatory cell homeostasis, increased immunosuppressive action, and reduced cytotoxic T lymphocytes. Similarly, low-dose chidamide, the HDAC inhibitor, also led to the TREC proliferation. These two molecules are currently in phase 2 studies for chronic ITP patients. Next is role of cytotoxic T cells and T follicular helper cells. So as I already said, that the balance shifts towards pro-inflammatory and cytotoxic T cells phenotype, leading to platelet and megakaryocyte lysis. They express more perforin and granzyme mediated cytotoxicity. The IL-27, which is anti-inflammatory, the secretion decreases in ITP patients, and so IL-27 might have a therapeutic role in ITP patients. With increased IL-27 levels, the shift can be from pro-inflammatory to the anti-inflammatory phenotype. The T follicular helper cells are a major component of B cell stimulation and generation of autoantibodies. So they are involved in formation of germinal centers and generating long-lived serological memory. So in ITP patients, there is increase in the splenic T follicular helper cells. They secrete increased levels of IL-21, and there is increased interaction between the CD40 ligand, that is CD154 on the T follicular helper, and the CD40 on the B cells, which leads to B cell recruitment, increased differentiation in the spleen, and conversion to antibody secreting long-lived plasma cells. So this mechanism of CD40 ligand and CD40 interactions was thought about in developing the novel agent anti-CD40 ligand antibody doralizumab. This was tested in preclinical studies, but it was not found to be effective. The B cell abnormalities in chronic ITP patients are important. If we compare the peripheral blood versus the bone marrow compartment, the B cell constitution of the peripheral blood versus the bone marrow compartment, we can see that in ITP patients, naive B cells are increased in the peripheral blood, whereas they are decreased in the bone marrow. The memory B, the plasma blast, and the short-lived plasma cells remain similar as to healthy controls, but there is an increase in the conversion of plasma blasts to long-lived plasma cells in the bone marrow, which secrete antibodies against platelet antigens. Also, the regulatory function, the B regulatory cell decrease, the TGF beta secretion, IL-10 secretion decreases, and the B cells exhibit an activating phenotype by increased interactions between CXCR5 and CXCL13. Also, there is overactivation of BAF and APRIL system in ITP. So now coming on to the therapeutics. Many novel therapeutic agents have been developed which target the various pathophysiological mechanisms that I have discussed earlier. We were using a lot of these products earlier also, and several new compounds have come in the last decade. So the agents targeting the reduction of antiplatelet antibody production and survival, we were already using splenectomy, corticosteroids, rituximab, and IVIG. The novel agents that I'll be discussing today are the neonatal FC receptor inhibitors, the roxarnolixizumab and efgartigimod, anti-CD38 and immunoproteasome inhibitors. They have been used in myeloma, but now they are coming up in ITP, daratumumab, bortezumab, hypersialylated IVIG, and recombinant FC multimers. I will not be discussing them in detail in view of time, but just to briefly summarize, the hypersialylated IVIG is nothing but IVIG with all its 4 glycosylation sites sialylated. That is, it is a sugar-coated IVIG. It is found in a percentage of 1 to 5% in the normal IVIG. And the studies have shown that it is the main active component of IVIG. So if we can produce commercially this hypersialylated IVIG, which has been produced in this molecule M254, the dose of IVIG that we administer could be reduced to 0.1 gram per kg, and the efficacy is increased several fold. So now this is known as super IVIG, which has been used and is coming up in trials in various autoimmune disorders. Second is the recombinant FC multimers that also act like IVIG. They block the FcRn receptors on the macrophages. Thereby, the autoantibodies cannot bind to these FC receptors and they are degraded. So it basically decreases the concentration of immunoglobulins, which are specifically directed towards platelet antigens. So the first novel agent that we'll be discussing is the neonatal FC receptor inhibitors. So what actually the neonatal FC receptor does? Neonatal FC receptor is expressed in various organs throughout the body. It is expressed in placenta, and it facilitates the transport of these immunoglobulins to the fetus, from the mother to the fetus. Then it is expressed in various organs, in liver, in kidney, in spleen, in central nervous system, and it basically increases the half-life of immunoglobulin released in the blood. So when the normal immunoglobulin or a pathogenic immunoglobulin comes in contact with these endothelial cells having FC receptors, it is first pinocytosed. Now in these endosomes which have an acidic pH, these immunoglobulins bind to the FC receptors and they form a compound. The bind form of immunoglobulins do not undergo lysosomal lysis. So they are retransported to the recycling endosomes and then released in the blood. This mechanism increases the life of immunoglobulin from 1 day to almost 21 days in the blood. And the FC receptors can bind both the normal immunoglobulins as well as the pathogenic immunoglobulins, increasing their lifespan. What do anti-FC receptors do? They competitively bind with these FC receptors in the acidic endosomes. Thereby, the normal immunoglobulin and the pathogenic immunoglobulin cannot bind the FC receptors, and it leads to the degradation of the immunoglobulins, which in turn leads to decreased lifespan of these immunoglobulins, and thus the destruction of platelets in ITP is reduced. So the first drug that was tested was roxanolixizumab. It was a phase 2 dose finding study, which was a multi-center open label study which included 66 patients of persistent or chronic ITP with a platelet count less than 30,000 at presentation. So these patients received almost 5 dose groups with 1 to 5 subcutaneous weekly injections. The cumulative total dose should be 15 to 21 mg per kg. So either they received 5 injections of 4 mg per kg weekly, or they received a single dose of 21 mg per kg subcutaneous injection. So we can see in this plot that mean serum IgG levels showed a decrease right from second day of infusion and reached a nadir at day 8 of the high dose infusions of roxanolixizumab. The decrease in the immunoglobulin levels coincided with the peaking of the platelet count. That is, in the high dose groups, the platelet count peaked at day 8 and started to increase right from day 1 of infusion of the this anti-FcRn antibody. If we see the different dose groups, the percentage of people responding showing a platelet count above 50,000 and most of the times of evaluation, it was 66.7% in 15 mg per kg group, and it was 54.5% in 20 mg per kg group. And we need to remember that these were multiply refractory patients having received corticosteroids 65%, TPO receptor agonist in 39%, splenectomy in 28%. And as I said, that these patients showed an early response. In the high dose groups, the patients responded starting from day 4, and maximum patients responded by day 8. So this is coming up as a major therapeutic option in refractory ITP cases, and roxanolixizumab and efgartigimod mod have entered the phase 3 studies. There are multiple these FcRn receptor antibodies which are being tried in multiple autoimmune diseases, including myasthenia gravis, pemphigus, warm autoimmune hemolytic anemias, and the results of these trials will pave way for a novel therapeutic agent in ITP. Second comes the complement mediated lysis. So the role of complement in immune thrombocytopenia has been described as early as 1985, when increased amounts of C3, C3b, C4 deposition were found on platelet surface in almost 70% of the ITP cases. 50% of these cases also showed that there was increased deposition of C9. Hypocomplementemia is found in 1/3 of the patients of primary ITP, and it is shown that these patients who have hypocomplementemia at the presentation of ITP have an increased risk of progression from primary ITP to SLE over the period of years. With C3b binding, it promotes more efficient phagocytosis through macrophages when C3b binds to C1R receptor on the macrophage surface, and C9 binding increases the risk of intravascular platelet lysis. So this biological mechanism was first tested by Erin Elizabeth and Catherine Broom in 2020, wherein they used C1 esterase inhibitor in 2 patients of secondary ITP, which were refractory to multiple agents. So what they concluded was that after giving the first dose of C1 esterase inhibitor, the platelet count started rising within 8 hours of infusion, and it was sustained in both these patients over a course of follow-up of 6 months. So this led to the testing of sutimlimab, first humanized monoclonal anti-C1s IgG4 antibody in chronic ITP patients. It is already approved in cold agglutinin disease. So in this phase 2 study, what was done, 16 patients were enrolled. They received sutimlimab infusions in part A of the treatment every alternate week, up to 21 weeks duration. And then they were assessed for response. After this, there was a wash-off period of 2 to 9 weeks. And those patients who responded in this part A of treatment were eligible for entering the part B treatment, wherein the sutimlimab was administered for up to 52 weeks every alternate weeks. If we see the response curves, we can see that with a mean basal platelet count of around 30,000 in all these patients combined, the platelet count started increasing from day one, and it peaked almost at day 7. And during the course of part A, most of the times the platelet count was well above 50,000. So the response was maintained throughout part A. But during the washout period, the platelet count again dropped to uh, less than 30,000. But in part B, when sutimlimab was again administered, the platelet count again rose and showed a constant response, with the majority of mean platelet counts being above 1 lakh platelet. We can also see the complement levels decrease significantly during the administration of this drug. So, this mechanism of targeting the complement can lead to a major breakthrough, because many of our patients who do not respond to multiple forms of antibody mediated mechanisms and the agents targeting them can respond to this, and it leads to a rapid response. Within hours of administration of sutimlimab, the platelet count rose. So in chronic ITP patients with bleeding manifestations, this might prove to be a boom. Further phase 3 trials are awaited, and these results were posted in 2023 itself. Next is daratumumab and bortezomib, which target the plasma cells. So we know that long-lived autoreactive plasma cells may be a source of treatment resistance in autoimmune cytopenias. Antiplatelet specific plasma cells have been detected in spleen of the rituximab refractory ITP patients. We have used daratumumab in multiple myeloma, bortezomib in multiple myeloma, which target specifically the plasma cells. Although the data currently is scarce, it is limited to case reports and case series. Recently, a multi-center open-label dose-escalating phase 2 study was started with daratumumab, known as the DART study. And the initial safety run-in phase, the results were reported recently with 3 patients of refractory ITP given weekly injections of daratumumab for 4 weeks. We can see that there was a response in the platelet count, and the response was sustained in one patient with minimal grade 3, grade 4 side effects. So this can be a promising approach. We already have the drug available with us. Next is proteasome inhibition. So we know that bortezomib is a constitutive proteasome inhibition. It leads to cytotoxicities as well. A new molecule KZR616, which is immunoproteasome specific inhibitor, is being developed and tested in phase 1 studies. So it does not cause cytotoxicity, but it reduces the inflammatory T helper cell, Tregs are increased, and it blocks the plasma cell formation in autoantibodies. Next mechanism is the inhibition of the macrophage function. So for this, we were already using corticosteroids, IVIG, vincristine, vinblastine, and splenectomy. Now, the newer agents that are coming are the SYK inhibitors and the BTK inhibitors. Fostamatinib is the first SYK inhibitor that has been FDA approved for the treatment of refractory ITP that has not responded to at least 2 agents. It was approved in 2018 after the results of the FIT1 and FIT2 trials. So what happens is, once the antibody-coated platelets bind to the FCR receptor, the SYK is activated, splenic tyrosine kinase. This splenic tyrosine kinase leads to the activation of the phosphorylation of the activation motifs downstream, and this leads to cytoskeletal rearrangement and platelet phagocytosis. So if we can block this splenic tyrosine kinase, the downstream pathways for cytoskeletal rearrangement and platelet phagocytosis can be impaired. The BTK also acts downstream of SYK in the same mechanism. SYK is also expressed in the B cells downstream to the B cell receptor, and it also involves in B cell receptor signaling and B cell proliferation and secretion of the antibodies. So this mechanism targets both these splenic tyrosine kinase activators. The dose is 100 to 150 mg BD, and it was postulated that a sick inhibition can also lead to inhibition of bacterial opsonization or neutrophil oxidative burst. But in clinical studies, it was not found to be true. The adverse effects that are noticed with fostamatinib are minimal. The severe adverse effects are seen in only 1 to 2%, that too diarrhea, hypertension, and nausea. Hypertension is believed because this sick inhibition also inhibits the VEGFR2. So if we see the FIT1 and FIT2 phase 3 studies, they enrolled a total of 101 patients and placebo of 49 patients. After 24 weeks of oral treatment, it was seen the stable response was seen in 18% of these multiply refractory patients, and overall response at any 2 times during the follow-up period was seen in almost 43% of the patients. So after these FIT1 and FIT2 studies, fostamatinib was approved for treatment of chronic ITP. This patient population was multiply refractory. The median time from diagnosis of ITP to study enrollment was 8.5 years. 75% of the patients had ITP for 3 years prior to enrollment in this study, and most patients had received more than 3 lines of therapy. So in this severely refractory population, it showed overall response rate of 43% and 18% stable responses over a year of follow-up. Recently, an extension study from the placebo group of FIT1 and FIT2, 44 subjects who originally received placebo were enrolled. 27 patients, that means almost more than 50%, achieved a stable response, and 78% maintained the response at 12 months. So it is highly efficacious. This trial is currently recruited. It is to see the real-world clinical experience with fostamatinib. The Forte trial, it is currently recruiting, and the results might come in the next 2 to 3 years. Then is the BTK inhibitors. BTK inhibitors, we all know, and we all are using them in lymphomas, in various lymphomas for years together. Rilzabrutinib is a new BTK inhibitor that actually is a reversible covalent BTK inhibitor with limited off-target site activity. If we see this PK exposure curve, we can see that after administration, the rilzabrutinib achieves almost 100% of BTK inhibition, and this effect lasts for almost 25 hours. Whereas the unbound BTK inhibitor rilzabrutinib is cleared from the circulation within 5 hours. So, because of its covalent binding, the long BTK target engagement, and durable BTK inhibition with limited off-site target activity, this is coming up as an agent to treat patients with ITP. The difference between ibrutinib and rilzabrutinib is that it is more selective for BTK. It does not inhibit the PI3-AKT pathway, which is notorious for causing atrial fibrillation, and it does not interfere with platelet aggregation and addition as is seen with ibrutinib. The phase 1, phase 2 trial with rilzabrutinib enrolled almost 45 patients to various dose levels. Some patients received 200 OD, some patients received 300 mg OD, and the highest dose group, 400 mg BID, was evaluated. And in this, almost 40% of the patients showed a response to rilzabrutinib. And we can see the response was prolonged and it was stable, almost 2 years of follow-up. If we see the primary efficacy responders of the patients who received the highest dose of rilzabrutinib, we can see that the duration of response, 95% of the weeks of follow-up, the patients had platelet count of more than 30,000, and 72% of the weeks of follow-up, the patients have a platelet count response of more than 50,000. The side effect profile was limited to grade 1 and grade 2, that to diarrhea, nausea, fatigue, which was minimal. Next is the stimulation of platelet production as a mechanism. We already are using TPO receptor agonist, romiplostim, L-Trombopag, avatrombopag. Heterotrombopag is a new TPO receptor agonist that I'll be discussing. Low-level laser light has shown to decrease the megakaryocyte apoptosis. So this is also one mechanism that is being tested in preclinical studies. So TPO receptor agonists, we know they can bind to the extracellular domain or they can bind to the transmembrane domain. Each of these have some side effects, with romiplostim leading to reticular fibrosis in 1 to 2% of cases. L-Trombopag has dietary restrictions, LFT derangements. Our Trombopag, though do not have any dietary restrictions, was approved in 2019, but it has increased risk of thrombosis. So a novel TPO receptor agonist, Trombopag, was developed in China. This phase 3 study with Trombopag showed that patients refractory to multiple agents responded fairly well, with the response rates reaching up to 80 to 90% in this patient population. This phase 3 trial included almost 424 patients. They were given 10-week treatment of Trombopag versus placebo. Then the patients who receive placebo during the initial phase can receive L-Trombopag during the open label 14-week treatment period. And then in the long-term extension period, the patients who received L-Trombopag, they can be shifted to Trombopag. Recently, the post-hoc analysis from this phase 3 trial was published in the subgroup analysis of patients who were switched from L-Trombopag to Heterotrombopag. And in this also, they showed that 70% of the patients who did not respond to L-Trombopag responded to Hetrombopag. Also, it is highly efficacious. The dose is very low and the side effect profile is very minimal in this TPO receptor agonist. The next mechanism is platelet deserialization and Asheville-Morel receptor. So what happens is, the platelets, which are coated by anti-GP1B9 antibodies, they fix the neuraminidase and lead to platelet deserialization. These desialated platelets are recognized by the Asheville-Morel receptors on the hepatocyte surface, and they undergo phagocytosis. So this mechanism of destruction is independent of the FC receptor mediated phagocytosis. And in patients who do not respond to the FC receptor mediated mechanisms, can respond to the neuraminidase inhibitor oseltamivir. Also, once these desialated platelets are destroyed by the hepatocytes, it leads to an activation of the JAK-STAT pathway and increased secretion of TPO. So this mechanism usually is a form of negative feedback for the regulation of TPO secretion. But once these antibodies are coated on the platelet surface, they undergo rapid deserialization. So the destruction of platelets increases. Oseltamivir, we already know the drug. It is a neuraminidase inhibitor. And in preclinical data, it was shown that it improved the platelet counts in mice. So this study on newly diagnosed patients with ITP, oseltamivir plus dexamethasone versus dexamethasone was tested, and the response at day 14 and sustained response at 6 months was statistically significant in the dexa plus oseltamivir group as compared to the dexa alone group. The side effect profile was limited to grade 1, grade 2 gastrointestinal and insomnia and anxiety. So again, revisiting our case, after studying so much about the mechanism and the novel therapeutic options, I felt, what else could we have done in this patient? We could have given therapy against long-lived plasma cells, daratumumab or bortezomib. Complement inhibition, though not available at present in India, can be tried. Oseltamivir can be a drug in these refractory cases, which encounters a different mechanism of destruction of platelets. Now, what should be our goals of therapy in ITP? The ASH guidelines, the updated review was published in 2019, and the treatment goals were specified. So they highlighted that the treatment goals should be individualized to the patient and the phase of the disease. Treatment should prevent severe bleeding episodes. Treatment should maintain a platelet target level of more than 20 to 30,000, and treatment should optimize the health-related quality of life. I have highlighted this point because in the IWISH study survey of almost 1,500 patients, they showed that most of the patients complained of reduced energy levels, reduced exercise capacity, reduced work-life balance, reduced capability to perform their everyday tasks, and increased absence from work as a major symptom of ITP. But amongst the physicians, what do we target as a treatment approach in ITP? We target either the reduction of bleeds or we target the platelet count. So after this webinar, I would like to discuss this point with our seniors and colleagues, that whether the goal of therapy in ITP should just be the reduction of bleeds and maintenance of a healthy platelet count of 30,000, or we should target these symptoms as well, because we have seen in our clinical practice that many of these patients are in agony because of the pains, the headaches, the reduced energy levels. So shouldn't we target the health related quality of life as the primary target of therapy in ITP, or we should just continue to target the platelet count? Now, how to sequence therapy in ITP? It depends on the frequency of bleeding, the comorbidities of patient values, whether they want an oral therapy or an injectable therapy, where they want a single therapy or they can continue therapy for prolonged periods, the various other medications, the availability and the cost. So in 2016, updated international consensus report on management of refractory ITP, they gave a tiered approach. So in newly diagnosed, we know corticosteroids and IVIG are the upfront modalities of therapy. In refractory cases, the first tier is with TPO receptor agonist, rituximab, and now fostamatinib is included. The second tier is other immunosuppressive agents like cyclosporin, cyclophosphamide, mycophenolate, dapsone, and the surgical option of a splenectomy. In tier 3, there are agents which we use seldom in ITP cases, ATRA, autologous HCT, plasma exchange, with variable response rates. So can we individualize therapy in ITP? Can we target certain mechanisms which respond to certain agents better than the others? So the first is, what is the mechanism of resistance? Chronic ITP may lose responsiveness over time. One reason could be evolution to MDS. Second is antigen epitope spread, upregulation of pumps that expel the treatments. The shift can be from primarily antibody driven to T cell driven. Long-lived plasma cells, expansion in spleen and bone marrow can result in refractory nature. And then GP1B antibodies, as I already showed, they are destroyed by the Asheville-Morel receptors. So if we can know the baseline status of the antibody profile in our patients, we know that they won't respond to steroids or IVIG. Or if there is absence of anti-platelet glycoprotein antibodies, they might not respond to rituximab or fostamatinib. So some of these investigative findings can help us streamline our therapy and can avoid the unnecessary failures of therapy in ITP. Now, when the standard second line fails, I have already discussed TYK inhibitor, BTK inhibitor, neonatal FcRn inhibitors, then the thrombopoietin receptor agonist, complement inhibitors, and daratumumab are still in trial. A word about combination therapies. Some retrospective studies have shown that the upfront use of combination therapies in severe ITP cases can lead to a good overall response rates and complete remission rates. There are various combinations that have been used: Dexa plus rituximab, Dexa plus L-trombopag, rituximab plus cyclophosphamide, danazole plus azathioprine, Atra plus danazole, with varying response rates. But all of this data is from retrospective studies or from case series. Coming on to the phase 3 trials that are currently ongoing in ITP, in newly diagnosed L-Trombopag versus standard therapy as first line, Avatrombopag versus placebo, Rilzabrutinib versus placebo, Luna-3 is in phase 3 trial, Roxanolixizumab and Efgartigimod are in phase 3 trials. So we have a lot of exciting data to be looked upon in the recent years, and hopefully these molecules will be approved for treatment of refractory thrombocytopenias, and we will be more equipped with these drugs, and maybe almost 90 to 100% cases of ITP can receive a cure. So in summary, the pathogenesis of ITP is heterogeneous, it is overlapping, multiple mechanisms can play a role in all of our ITP patients. Trial and error mode is still the method of choice to determine effective therapy. Effective therapy must show increased desired effects balanced against undesirable effects. Frontline rituximab, MMF, TPO receptor agonist may improve response rates by targeting different mechanisms at the same time. Randomized trials in the first-line settings with long-term follow-up and patient-reported outcomes are the need of the hour. With multiple options for second-line therapies, we should take into account the age, the comorbidities, the preferences of the patient in making our treatment decisions. Continued efforts are needed to better understand the pathophysiological reasons that why some patients respond better than others. And there are multiple ongoing trials, but so far there is no cure for ITP. Thank you.
Thank you, Dr. Priyanka. That was fantastic. Your depth of understanding of the subject is to be appreciated. You put forward the mechanism and the pathophysiology so elaborately. There's a lot of learning. And also, second part of your talk on management was also real update, and the research which is ongoing was an eye-opener. Thank you so much.
Thank you.
A lot of learning. Thank you. So let's come to the discussion. Are there any hand raised? Anybody? Yeah, come, Dr. Rita.
Good afternoon, everyone. I hope I am audible.
You are audible.
Yeah, thank you. Thanks for the lucid presentation, Dr. Priyanka. ITP, I know if they respond to first-line drugs, patients are happy, doctor is happy, but if they do not, it's really difficult to treat situation. So do you think that newly diagnosed, persistent and chronic ITP, they are different diseases, or it is just one disease evolving into another with so much new knowledge upcoming on pathophysiology? What is your take on that?
Yes, I think it is a continuum. So most of the newly diagnosed cases, if we see the pediatric population, they are self-limited. Whereas the persistent and chronic ITP cases, they generate certain mechanisms that become difficult to treat. As I have already highlighted, that some of these mechanisms leading to resistance could be the appearance of long-lived plasma cells, which continuously secrete antibodies, or the antigen epitope spread, with new antigens coming in each time, so that we target one and another one pops up, leading to other antibody generations. Also, the patients who are not responding to rituximab or to TPO receptor agonists, they have some clonal expansion of T cells. So T cell mediated lysis becomes the major mechanism in those patients. So I think it is a continuum which has a predisposition. So the genetic predispositions, the various polymorphisms that guide that whether this patient will have a self-limited ITP or this ITP will continue on for long. So I think that.
Thank you. Can I ask one more question, sir?
Yes, Dr.
Yeah, are there, like, there are so many new lab tests coming up, like you said, along with antiplatelet antibodies, MIPA and Fc gamma are 2B.
Yes.
Are they available to us?
No, they are not available for clinical practice, but I think they might change the treatment landscape once they are available.
They can help in predicting the
Yes.
response to therapy and all. That is why.
Yes, and guiding individualized therapy as well.
Thank you.
Thank you, Dr. Rita. Dr. Priyanka, can you stop sharing your screen?
Yeah, sure, sir.
Good. Okay, so before we go to Dr. Nikhil, take a question from the audience. Do you think that MPV is a predictor test for the response to splenectomy?
MPV usually is elevated in immune thrombocytopenia. It shows us that the immature platelet fraction is higher. That shows that the production mechanism is not altered. It's the destruction that is taking place. The second part of the question, sir, in predicting response to splenectomy, I'm not aware of any such data per se.
Thank you. Dr. Nikhil, your question. Unmute yourself, Nikhil.
Thank you, Dr. Priyanka. That was an excellent presentation. I have a couple of questions. My first one is regarding H. pylori testing. So in patients who have some sort of gastric symptoms, do you routinely test for H. pylori? And if so, how? Do you do a ureate breath test, or do you go ahead with an endoscopy and a biopsy to test for H. pylori? And in your experience, how is the treatment response to H. pylori eradication if patients are detected to be positive by either of these two tests?
Yes, the patients who have gastric symptoms. So in the last 2 years, I found almost 5% of patients of ITP that I dealt with were H. pylori positive. So now I make it a point to take in history the gastric symptoms. And if they have gastric symptoms that are persistent, I go for endoscopy because urea breath test is not available at our center. And I have seen in all these patients, they respond beautifully to H. pylori eradication therapy. The thrombocytopenia resolves on its own. So, instead of treating them with immunosuppression, if just the cure for H. pylori can eradicate ITP, that is quite convenient mechanism.
Yes, definitely. And my second question is regarding the second-line therapy. With TPORAs, whether it is romiplostim or eltrumopag, how long do you wait before labeling them as TPORA refractory? And up to what dose of romiplostim or eltrumopag do you go for the same?
Usual definitions say at least 12 weeks we should wait. I wait for almost 8 weeks before labeling them as refractory. And the maximum dose that I have used is 500 microgram weekly dose.
Okay, that would be around 10 micrograms
10 micrograms per kg.
Roughly.
Yes.
And my other question is, if the patients are multiply refractory, especially adolescents and young adults, before you go on with the third or fourth line of therapy, do you evaluate them for inherited platelet disorders? Do you get an NGS done just to see if there is a mutation?
Yes, I have started doing it recently. Although many patients are non-affordable, we cannot get it done in all. But I make it a point who are multiply refractory. I look for inherited thrombocytopenias in them as well before undergoing a splenectomy, especially.
And in these multiply refractory patients, how was your experience with bortezomib or daratumumab prior to splenectomy? Do you give them a trial of these new treatments prior to splenectomy?
I have given in a couple of patients. Not much experience as of now. Yes.
Thank you so much.
Thank you.
Thank you, Nikhil. And before we go to Dr. Arun VA, one question from the audience. You presented a case where anti-nuclear antibody was strongly positive. He wants to know whether you act on this, whether you would like to add HCQ to such patients. Are there any other differences in the management of the patient who do not have overt SLE, but have a strongly positive ANA?
Yes. I think the complement inhibition is a major mechanism in these cases. So if we have complement inhibitors available with us, I think I will go earlier on them. Also, the T cell blocking mechanisms, like we added mycophenolate earlier in this patient because we thought that might be there might be a role of mycophenolate in these autoimmune disorders. But this patient did not respond to that also. So I think, and rituximab earlier in these patients, because some studies have shown that rituximab as a first-line therapy in patients with ANA positivity have an increased response rate. So these three mechanisms, I think we can target in such patients.
Thank you. Yes, Dr. Arun B.A., go ahead.
Thank you, sir. This is a question regarding the line of management and the sequencing of therapy, which actually you took for managing this case. So this is just a query, because if you go into the biology, and when we know the minimum time to response for MMF may be at least 3 to 4 weeks, rituximab and TPORA at least a week before they start acting. When somebody is having an acute severe ITP, and we have like used steroids in some form and IVIG upfront, I think should it be wise to move to splenectomy as a choice in this patient who's having a bleeding profile, critical site bleed, because we waited almost for day 18 for splenectomy to come in. And danazol and MMF, I don't think they have any role in an acute severe ITP patient wherein we have to hit hard and hit faster. So I just thought, was the sequence in which we chose the therapy, if we would have chosen steroid, IVIG, and splenectomy upfront, and definitely we will have to use rituxi and TPOR at some point of time, but you can't dwell on them. They won't give you a response in at least in the first week or so. So I thought, is the sequence of therapy, if you could modify, the outcome could have been different.
Yes, yeah, I reviewed this case and we were thinking that could splenectomy earlier would have helped. Actually, we discussed with the surgeon at our center, and since she was having bleeding manifestations, they thought it would be wiser to, postpone splenectomy a little in this unstable patients with bleed. There was no response to any of the above therapies. We went for splenectomy. Yes, you are correct that splenectomy could have been done earlier, that we were also reviewing in our review meet. Another thing is that many of my patients who were ANA positive, they responded very well to mycophenolate within the first week. So we didn't have to wait for them like you said, that mycophenolate can take almost 4 to 8 weeks to respond, but many of my patients responded within the first week with mycophenolate. The same patient population, female patients with ANA positivity. So I thought, and in discussion with the immunologist at our center, we thought that adding on mycophenolate earlier would help. But yes, splenectomy could have been tried earlier, but even after splenectomy, this patient didn't respond. So that is another caveat in this case.
Okay, thank you, Dr. Arun. We'll go to one more question from the audience. If a patient responds to the TPO receptor agonists, how long do you continue them? How do you taper? And finally, what do you do with them?
So this is a difficult question. I usually continue for almost 6 months. Then I increase the duration. Like in romiplostim, if I am giving weekly, I increase to 10 days, then 14 days, and then gradually taper it off. In Revolade, what I do is reduce the doses and bring it to a minimum dose, and then maybe alternate day therapy. And still, if the platelet is above 1.5 lakhs, I stop therapy with the TPO receptor agonist. At least for 6 months, I continue.
Thank you. Dr. Vishnu?
Hi, Priyanka, and hello, Dr. Agarwal. Thank you for inviting me to this excellent presentation. I want to first of all congratulate you, Priyanka. It was excellent overview, and thank you very much. I really sympathize with you on losing a patient with ITP. It can be very painful to see a patient succumb to a non-malignant benign hematological disorder. I'm sure this would stay with you for a long time. But we move along, we learn as we go. Because we've been talking about splenectomy, I want to ask, where do you place it in your clinical practice, given that we have so many options? And ITP, thankfully, most of the time is not a serious disorder.
So in pediatric patients, I keep it at a later stage in my management. In adult patients, if they want a permanent cure to the disease, I might take it up after using steroids, of course, TPO receptor agonists, some form of immunosuppression, and if it is not responding to these 3-4 lines of therapy, I would consider them for splenectomy.
Okay. That's very interesting, because surgery is always something patients are, I mean, at least in patients whom I see, they're always petrified. And especially with a low platelet count, and these patients on immunosuppression can be a challenge with infections. Have you used rituximab again in a patient who has responded before? What is your opinion on that, please?
Yes, we have rechallenged with rituximab with varying response rates. We have.
And how would you select these patients, if you don't mind me asking?
The patients who initially responded very well to rituximab therapy and they relapse after say a gap of 6 months or 8 months after rituximab, those patients I think can be a candidate for rechallenge, because the rituximab, the B cell population again comes to its normal level, so we can rechallenge them as far as my knowledge is concerned.
Okay, yeah, thank you very much. Again,
Thank you.
appreciate your lecture. Thank you.
Thank you.
Thank you, Vishnu. I'm a little tempted to answer your question in a slightly different way.
Yes.
An old man's version.
Yes.
So we used to do a lot of splenectomy in 1980s. With the availability of rituximab, it significantly came down. And then with the availability of TPO receptor agonists, it has almost become a sort of solid treatment in our routine practice. Still, we do it in two situations. One is the type of patient that Priyanka presented, whether it is upfront or whether it is after years of struggle. If you've got a symptomatic, refractory, definitely proven ITP, where all the modality of treatment existing in your armamentarium in your country, you've exhausted with, I think reluctantly you offer this because you are concerned, because that's that 0.1% of patients of ITP who can have significant morbidity, mortality due to the ITP. So sometimes it takes months and years of struggle before you finally accept this as your treatment. Second, on this part of the world, there are patients who do not have an access to even a reliable platelet count. They do not have access to a very good quality pediatrician or physician. Forget about hematologists. They stay so far that they cannot reach the cities, and they are financially so weak that they cannot keep coming to you for follow-up. Now, in that kind of patient, it is better to offer a curative treatment rather to keep struggling and hospitalization, somebody pumping in platelets, somebody pumping in steroids and steroids and steroids. So we are a little more practical for that kind of child or adult coming from a very remote place with no financial support whatsoever. But this is one-time treatment which can cure that patient who otherwise is left to coax virtually. So having said that, in last 10 years, I don't think I've done a single splenectomy. I must say that. About rituximab also, I would like to say, there are patients who are happy to take a periodic L-Thrombopag or Romiplastim, and there are others who are sick of taking these drugs for months and years. They don't mind taking rituximab, a couple of doses, once every year or once in 2 years. And rituximab has efficacy lasting for 1 year or more. And it can be as simple as 1 dose of rituximab. You don't have to really give 4 doses and all that. And we have patients who just take 1 dose once in a year, once in 2 years, and their platelets are at asymptomatic level. So those who prefer to just take intermittent treatment, there is a good place for that drug.
Yeah. No, thank you very much, Prof. Agarwal.
Thank you, sir.
Those were, very, very helpful practical tips. Thank you.
Thank you so much. Now, one more question from the audience now. And that's related to, when do you look out for the antiphospholipid syndrome in a patient who is a young female with ITP? And if the lab test comes positive with no clinical equivalent, will you be concerned about giving the TPO receptor agonists as they may produce thrombosis?
I have not encountered such a case. But yes, I think I'll be reluctant in giving L-Trombopag in such patients. For testing, if a patient is refractory, a young patient, I think to do APLA at the baseline will help in the diagnosis as well as in the management. So yes, in such patient population, we can check for APLA profile as well. And the investigation lists that have been highlighted, they also include APLA profile in the initial investigation of such patients.
Thank you. Dr. Asha Shah, your question.
Excellent presentation, Doctor.
Thank you.
We learned a lot. One question, any role of monitoring the rise or just before it rises with IPF?
Yes.
Like
So
how we
immature,
monitor in autoimmune hemolytic anemia with
yeah.
retic count?
So immature platelet function at the baseline can help in deciding the treatment, because if the immature platelet function is high, we know that the production part is okay. So the megakaryocytes are producing platelets. So the role of TPO receptor agonists in such situations, they can be used a little later in the management algorithm. As far as monitoring with immature platelet count is concerned, I am not sure about any data with as such, because immature platelet function can be increased at the baseline itself. So how to monitor them, whether it decreases or not during the course of ITP treatment, I'm really not sure about it. Maybe sir can pitch in.
I would say, Dr. Asha, it's a good test to make a diagnosis whether marrow is functional or not functional. But I wonder whether you can really use it for treatment or follow-up. I don't think we have any guidelines or practical experience to divert your treatment based just because your indicators are that the marrow is functional or non-functional. Patients with hardly any evidence of marrow functional or not may still respond to the usual treatment and vice versa. So I don't think your treatment will be changed, or you can follow up the patient with these parameters. As diagnostic front, yes, it does help you. In dengue, etc., you can use this.
Yes.
Where you are recovering marrow, and then you can stop giving platelet support, etc. Yes, but in ITP, I wonder. Yeah.
Thank you, sir.
Any more question, Asha?
Another one most difficult question which patients always ask is, or they want, is that the treatment should be for a short period or finite period, and there should be a long non-treatment interval. So there, one we have rituximab, or in some patients, very selected patients, splenectomy, but although it is going less and less, as sir mentioned. In any of these newer treatment modalities that you mentioned, do you see any of those promising?
I think the BTK inhibitors, they showed a response for a long period of time, even after treatment discontinuation. So they can be one option in such patients. And even FcRn receptor antagonist, they have also shown that even after a gap period, the patients still continue to respond to those therapies. So it is like continuous plasmapheresis that we are giving in the form of subcutaneous treatment. So these two options might be the future in such patients.
Thank you. Thank you very much.
Thank you.
Thanks, Dr. Asha. One more question from the audience. This is from Dr. Nusrat Tazeen. Your comments on managing recurrent gestational thrombocytopenia.
So in recurrent gestational thrombocytopenia, the treatment modalities that I use presently are low-dose steroids. The TPO receptor agonists have also proven to be safe in some retrospective studies, though there is no prospective data. And other is IVIG just before delivery to ensure a safe delivery. So these three options, and azathioprine is used with variable response rates. So these four options currently are being used in gestational thrombocytopenia.
So Dr. Nusrat Tazeen, Dr. Priyanka has just told you the management of ITP during
Immune thrombocytopenia, yes, sorry, not gestational, yes, sir.
So
So the gestational thrombocytopenia cases generally do not present with severe thrombocytopenia. And just after delivery, the platelet count returns back to normal. So I don't think with gestational thrombocytopenia, you are much worried. You can just give platelet transfusions during delivery and conduct a safe delivery, and then the platelet count reverts back to normal. So I'm not using any other modality in gestational thrombocytopenia.
right. So just one comment over there. When the woman is first time presenting to you, it does become impossible to differentiate whether it's a mild ITP or it's a gestational thrombocytopenia. When it's recurrent, it is so easy because between the pregnancy, her platelet count has to be absolutely normal to call it a gestational thrombocytopenia. Having said that, platelet count never goes below 65,000. So whether it is mild ITP or it is gestational thrombocytopenia, it is masterly inactivity. At 65,000, you don't want to touch the woman either way. So yes, Dr. Priyanka is absolutely right. Just keep away from treating these patients. You don't need any treatment. But you should be very confident of the diagnosis. Right. Dr. Anju Bharti, your question.
Thank you, Dr. Priyanka, for those newer insights into pathophysiology and treatment of ITP. You have elaborated your topic very well. And my first question to you is, what are the chances of bleeding in neonate of a mother with ITP, and how do you manage those patients?
Yes, so neonatal alloimmune thrombocytopenia, these patients can have serious bleeding at birth. They can have intracranial hemorrhages as well. So a detailed history, the mother's baseline investigations to diagnose ITP, and then serial monitoring in the neonate with ITP is essential from birth to at least 1 month post-birth to prevent these complications with CNS bleeding.
And what treatment you are offering if they have serious complications?
If they have these bleeds, I think I will go for IVIG as the treatment in such patients.
Okay. And my second question is, at the same level of platelets, some patients do not have bleeding, while some patients have severe bleeding. What may be the reason for this?
One could be the immature platelet fraction, that is available, whether the production of platelets from the marrow is there. And second is the age, the comorbidities, whether it is primary versus secondary ITP. Some studies have also shown that there is the structural abnormalities in the vessel wall in such patients who present with more severe bleeds in ITP. So as far as I know, I have studied, these could be the reasons, wherein some patients bleed profusely while the others do not bleed with the same platelet count.
Thank you, Dr. Priyanka.
Thank you.
Thank you, Dr. Anju. Before we come to Dr. Swati, one more question from the audience. Have you used Eltrombopag and Romiplastin together? Can we do this and when?
I haven't used it together, but I have changed over from one to another.
Right. Dr. Swati, your question.
Priyanka, very, very good talk. Good. You taught us a lot. Tell me, when you do an NGS for your chronic ITP patients, in what percentage are you likely to get something? Like, what is the yield of doing an NGS in your experience?
In my experience, I have done in a few patients, in a couple of patients. One patient had ETV6 mutation detected in that, the other did not. So I do not have very vast experience of using NGS. So I'm not the right person to answer this question, I think.
Okay.
The literature says that 15% of such cases can have inherited thrombocytopenia.
Sir, would you tell, like, in your experience or anybody else's, like when we do an NGS, which is an expensive test. It's finally done out of frustration. You don't know what else you can offer the child, and you do it. And invariably, you don't get something, So what is the experience of the rest of the people here?
So Swatik, basic idea is that you want to differentiate between congenital versus an immune thrombocytopenia. So as you know that congenital thrombocytopenia often have clinical clues. They may have some kind of other organ abnormalities, congenital malformations, other system involvements, etc. So they can be a clinical clue. Keeping all that apart, if there is no clue whatsoever, if the patient has significant response to IV gamma globulin even once, then those are patients of immune thrombocytopenia, because that is one drug which just does not work in congenital. So you use that as a therapeutic test to again rule out patients who are really ITP only and just refractory. Again, if the patient does not respond to IV gamma globulin and patient is a refractory chronic symptomatic thrombocytopenia, as Priyanka said, in all patients, you need to know whether your diagnosis is wrong. In all patients. So now you are going to leave that person with a lifelong thrombocytopenia or a long-term thrombocytopenia, which is symptomatic with morbidity, with mortality. Somebody is going to do splenectomy. Somebody is going to give him drugs of which he can have side effects. Again, may die of that treatment. So in all those patients, children or adult, including MDS for the adults, congenital for the young people, you need to go to the depth. And I think once you explain the person that money spent of 20, 30, 40, 50,000 for all these investigations is worth it. Otherwise, you'll end up spending more money on the wrong treatment with all the complications of the treatment. Don't you see patients who have lost their spleen unnecessarily? And you see the side effects of the drugs, immunosuppression, serious infections, organ damage, morbidity, mortality. Immunosuppressive treatment in our era where there are antimicrobial agents which are totally resistant is often even fatal. So to some extent, I think it is mind block of the hematologist that this is expensive. This expensive is a very relative term today.
But sir, this was through personal experience that I have hardly got anybody, even when we are trying to rule out a primary immunodeficiency, and I see Amreen popping up there. So when we are trying to, in pediatrics, we are trying to find out whether there's a primary immunodeficiency, and we do the NGS. Amreen, any thoughts on that?
Ma'am, we've had more success with Evan's phenotype than we've had with just ITP. It would be 20-30%, not more than that. But in the ones you pick it up and you give them like the correct therapy, it works like magic. So it's worth doing the test.
That is true. That is true. Just that the yield is not,
So as it is said that when you suspect meningitis and you do a lumbar puncture and 10 out of 10 had meningitis, you have missed 90% of the patients. So your yield should be 5 to 10%. Otherwise, you are underdoing a test for anything. Whether it's a CT scan of the brain, whether it is CT scan of the abdomen, whether it is blood test, if every patient has got a positive outcome, then you're probably not doing it optimally. You're missing a lot. So negative results will be there. And they should be there for 90% of the patients. Then you're probably doing it for everybody.
Correct, sir. Yeah. Thank you. Thank you, sir.
Okay. Dr. Amit, your question.
Thank you, sir. Excellent talk, ma'am. Regarding the recent advances in the ITP. Actually, there was a wonderful paper which was published in 2021 December and January 2022 regarding the use of all-trans-detergonic acid, ETRA, in the treatment of refractory ITP. And it was in combination with ETRA plus danazole as well as ETRA plus low-dose rituximab. Can you please throw light on that, whether this is really effective?
Yeah, so in the combination therapies, I have shown this as a treatment modality. It was based on this study, which showed an overall response rate, if I'm not wrong, more than 70% in multiply refractory patients. So yes, and both these drugs are available with us. So in such refractory cases, if 70% overall response rates with minimal toxicity, we can definitely try this combination as well. It is the mechanism was mainly immunomodulatory. So I think it can work in various subsets of these ITP patients.
Because they said that there is more of megakaryocyte differentiation as well as increase of Tregs.
Yes, T regulatory cells increased to a great extent in that study. Yes, so we can try, I think.
Thank you, ma'am. Yeah.
Amit, one comment here.
Yes.
It came in a very prestigious journal, so it became a talk of the town. But it came from a country where there were question marks, and then she quoted a large number of papers, and those are the champions of ITP. So Duker and others have tried it in their lab at the experimental level, and they've tried it in small percentage of patients, and their experience has been that nothing great is happening to the patient. So they feel that this needs more documentation before being released to the patients in clinical care. So take it with a little pinch only. It's not yet confirmed in large trials from Western world.
Yes, sir. Thank you, sir.
There is a remark by Dr. S.K. Sharma. He has something to tell you about H. pylori. Once you suspect H. pylori as a possible etiology and patient has GI symptoms, an endoscopy is essential as it may reveal the cause of the GI symptom too. Even more important is confirmation of the H. pylori eradication by urea breath test and not repeat endoscopy except in a case of gastric ulcer. The motto is test, treat, and confirm. So that is just a comment, so no discussion on that. The next question from the audience is from Dr. Shyam. Is splenic artery embolization an option for a patient who is a difficult case to undergo emergency splenectomy?
Oh, sir, I have no experience with that.
I may just say that splenic artery embolization has been done as a desperate situation, just like Priyanka's patient. If they don't give consent for splenectomy, or you feel that your surgeon is absolutely refusing to subject the patient to splenectomy, or medically the patient is unfit for splenectomy. However, in a routine practice, it's an extremely painful test. The infarct that it produces, the pain is unbearable. You have to virtually dope the patient with narcotics for a couple of days. And also there is a risk of abscess formation. That, in fact, if there is a nidus of bacteria lodging in there, you can get abscess. We could treat one patient with aspiration of the abscess, and another patient we have to splenectomize the patient to save life. So it's an anecdotal treatment for an anecdotal situation. Dr. Hamza, your question.
Thank you, Dr. Priyanka, for the elaborate review of at least newer modalities of treatment in ITP. Actually, I have a comment and a question. So, this thing in chronic ITP, it is also as much important as to know when to treat as to when not to treat. So, I have in my practice found tranexamic acid to be a really useful drug to for minor bleeding symptoms. So, do you have any experience with that, and how should we place tranexamic acid, especially in chronic ITP patients?
For mucosal bleeds, oral bleeds, minor bleeds, we can use tranexamic acid. But usually at 30,000 or above, we do not see bleeds per se in chronic ITP patients. Even for that matter, even patients with more than 10,000 platelet count, they also do not bleed in chronic ITP because of the adaptive mechanisms. So yes, it can be used in certain situations where minor bleeds are there, and the patient is refractory to multiple agents or multiple therapies. But once the patient has wet bleeds evident, they are at increased risk of bleeds from danger sites as well. So we have to be a little cautious in them.
Okay, so we have kind of avoided escalating treatment in quite a few patients via short courses of tranexamic acid intermittently. I think it's a very useful drug. Another comment about NGS, like sir said, that it is very essential to rule out inherited thrombocytopenia. But one of the problems that we face in clinical practice is that many times you get reports with variants of uncertain significance. Like recently, I had a young lady who had an ITB3 mutation, which is a variant of uncertain significance associated with inherited thrombocytopenia. So what do you do with these patients? Will you consider continuing the treatment of ITP, or will you then change the treatment? Because the alternative treatments for this is either platelet transfusions or to go ahead with a bone marrow transplant. There is no other alternative here.
So yes, the NGS, when it gives such variants of unknown significance, it becomes difficult. I also had a patient who tested for Glanzmann thrombocytopenia that was a heterozygous mutation. So then you do not know where to go ahead with these patients, and you cannot offer transplant in each and every patient's. Sometimes donors are not available. Sometimes patients themselves are not willing to go for transplant for relatively simple disorder. So I do not know. I think with more experience, we'll get to know that where to place NGS, and when these variants of unknown significance are detected, whether to continue with the same treatment or to straight away go ahead with bone marrow transplantation. I'm currently I'm not in a position to definitely comment on this situation.
So my patient luckily responded to L-Trombopag, and now she's on tapering doses. So yeah, that helps, I
Okay.
think.
Yeah.
Thank you, sir.
Again, Hamza, I don't know whether that solves out your problem, because some of the congenital thrombocytopenia have excellent response to L-Trombopag. So the response to L-Trombopag does not really is a diagnostic test. Like IV gamma globulin is a diagnostic test.
Correct, sir.
Platelet transfusion and no response, no increment to the platelet in an hour is a diagnostic test, at least of an immune mediated, whatever may be the type of immune system involved. So if your patient has no increment in the platelet count at 1 hour after platelet transfusion, then probably that's not a candidate for bone marrow transplant. It's a platelet destruction that is going on. So you can make a lot of clinical clues in selecting a patient who is a marrow patient and who is not a bone marrow patient.
So just one question, sir. So will you take this patient of L-Trombopag, or you'll just continue as long as she's responding?
She's responding. So who cares what is the diagnosis?
Okay.
Patient who is responding with such a simple treatment, which can be given for lifelong without much toxicity.
Without much toxicity.
Yes, of course. I think simple clinical logic is more important than going into complex NGS panels.
Right. True, sir.
Dr. Amrin, before your question, I'll take up one from the audience. So you have a patient. This is a question from Dr. Mona Vijayaran. She's a hematologist herself from Lucknow. Only you must be knowing that. So there's a 45-year-old male who has got a retroperitoneal lymph node mass, which is suspected to be a lymphoma. The platelet count is 10,000. The bone marrow is not involved by lymphoma, and there are increased MEX. So they think this is a lymphoma with a secondary ITP. Now, how will you go around doing a lymph node biopsy in this patient?
In this patient, we can get a core biopsy done. We can give certain therapies for ITP per se. Low dose steroids help. A short course of low dose steroids help in such cases, and then we can get a core biopsy done and get the diagnosis. And if it is confirmed as lymphoma, the treatment directed towards lymphoma will in itself cure the thrombocytopenia as well.
Right. And Mona, if you are concerned about steroid coming in the way of your diagnosis, the lymphoma may melt away, then you can use the foolproof IV gamma globulin.
IVIG.
Yeah, that works nicely. So you can just raise the platelet count to a level where you can easily do a proper biopsy. Yeah, sure. Amrin, your question.
Hi, Priyanka. It was a lovely talk. Honestly, you've covered it so elaborately in terms of mechanisms. And I think with an unknown disease, it makes it really important that we know the mechanisms. I have not used BTK inhibitors in my practice, honestly, but my understanding is that they do cause platelet dysfunction. How does that then fit in with using it with ITP? Have you had any experience from that point?
The earlier BTK inhibitors like ibrutinib, they had the defect of platelet aggregation. But with the newer agent, this rilzabrutinib, they have shown that there is no effect on platelet aggregation. So they have used safely in phase 2 studies, and they have not seen any disorder of platelet aggregation with this newer molecule. So that's why it is specifically used for ITP patients. So I think with this molecule being it safe in platelet aggregation, it can be used for ITP.
Thank you.
Absolutely. I think both the BTK inhibitor available in India, they have nothing to do with treatment of ITP and must not be used. So Priyanka is absolutely right there. One more question from the audience. So you have a 33-week pregnant woman. She's not responding. She's got ITP and she's not responding to IV gamma globulin. She's not responding to steroids. And probably it's a severe thrombocytopenia. What will be your next step?
As I already said that I have used a TPO receptor agonist in such cases, and they have shown response to them. So though they are category C, but so far in retrospective studies, none of them have shown to be really toxic to either to the fetus in the earlier trimesters or causing any growth restrictions in these patient population. So I think that could be an option.
Right. And Dr. Nasrin, if your patient is not responding to IV gamma globulin and steroid, check the diagnosis also. Whether it's really ITP. And then if it's ITP, yes, you can use TPO RAs in the third trimester. As such, you need only the para-delivery period management. If the woman is not bleeding, you can leave her alone with 10,000-15,000 of platelet through and through. Dr. Subhash Jha, your question. Dr. Subhash. We are not able to hear you, Dr. Subhash. Okay, we'll take up a question from the audience. Dr. Vinayak Chikodi has asked, do accelerated destruction and impairment of production equally contribute to thrombocytopenia in ITP?
They both contribute equally, I'm not sure, because more than 70% of the cases have immune destruction as a major mechanism. But in 30 to 40% of the cases, the production is also defective because the autoimmune process also involves the megakaryocytes. So the exact equal percentages I'm not aware of, but yes, they both contribute to the development of immune thrombocytopenia.
Thank you. Dr. Subhash Jha, can you try again your question? Okay, we'll go to Dr. Dheeraj Bhatte.
Dr. Priyanka, first of all, very impressive and exhaustive talk. I was like very impressed. What I would like to take this opportunity and take liberty, sir. Basically, all the questions have been covered. But being a physician also, I just want to know of all this pathophysiology which you've viewed, any medicine you could found useful for dengue? I know it's self-limiting thrombocytopenia, but we very commonly see and we are in stress. With so much research going on IT, we are very impressed. I was surprised. Could you get any reference for any very severe thrombocytopenia in dengue for any of these molecules?
So intravenous immunoglobulin has been used in severe thrombocytopenia in dengue. Patients respond to the same. Amongst the newer molecules, I don't think they have covered dengue as such in the trials. So as far as my experience is concerned, I have used IVIG in a few patients of dengue with severe bleeding manifestations, and they have responded well to IVIG. So that can be tried.
Hello, sir. Good morning. Dr. Sija from Patna. Sir, I am audible or not?
You are audible now. Go ahead.
Yes, sir. Thanks for giving the opportunity to participate as a discussant in this ITP-related management. And I congratulate Priyanka Chauhan for past, present, and future, especially complex pathophysiology is dealt so nicely in a lovely way. So I would like to, sir, there are so many questions asked. I would like to explain my experience in Bihar. I have to face the upfront the new cases, a very challenging ICU setup especially. My question from Dr. Priyanka is, in her first case presentation, did she use dexamethasone IVG together to manage the intracranial hemorrhage or not? This is a question.
Yeah.
Other question is
Dr.
related
Subhash,
to
Subhash,
yes.
one question at a time.
Okay, sir.
We used IVIG together with prednisolone, and we used dexapulses later on in the management course. So we didn't give dexamethasone with IVIG together in this patient.
Other question is if you use dexamethasone in my 2 cases of my experience in pregnancy, that is a refractory to methylprednisolone, oral prednisone, and other IVIG, refractory to both. But when during the delivery, LSCS was planned, and she was given dexamethasone 4 days before the planned LSCS, it worked well, and platelet came to around 60,000. So I think dexamethasone drug of emergency. Other steroid it could work in better way if the as sir really said, it must be a truly ITP case. So dexamethasone could be drug of choice in emergency. And last question is any experience of fosamatinib availability
No,
in
it's
India
not,
or not?
not available in India.
Will request sir to give the answer. So,
yes, so what
pregnancy,
Priyanka said is correct. The molecule is not at the moment available to us, but yes, in the Western world, it has been approved, and because it is very efficacious and reasonably free from side effects, it is used quite upfront in the patients. So we have had patients who corresponded by emails who have received this compound right as the second line of treatment. But we don't have an access to it.
Sir, this drug could be said as the pharmacological splenectomy.
Almost, yeah.
Yes.
Almost.
Thank you, sir.
So we come back with one more question. I just want to say one comment, Dr. Subhash.
Yes.
There is enough literature to say that when steroids are given in equivalent doses, and if the patient is absorbing them well, then what you use and how you use is immaterial. The response is identical. So there's a lot of literature on trying one steroid with the other steroid, one dose with the other dose, IV with oral, etc., etc. But at the end of the day, the pundits feel that there is no difference much.
Sir, but my choice of drug in emergency always emergency ICU setup. Always IV, so methylprednisolone or dexamethasone. That is choice, and 1 gram tranexamic acid is also given together.
Sure. Yes, last question, I think almost. That is, can we use Atrembopac 150 mg OD in a patient of ITP?
So in ITP, the maximum dose recommended is 75 milligram. In aplastic anemia, we have used the dose of 150 without any major side effects. I think we can try it in ITP also because the side effect profile is quite safe, but I do not see whether it will improve the response rates in ITP.
Yeah, absolutely right, Dr. Priyanka. Dr. Rizwan, 3 doses for 3 diseases. ITP up to 75, aplastic up to 150, and myelodysplastic up to 300. So just remember this formula, because sometimes excess of doses and then you can have some little bit of complications. Okay, that was the last question from the audience. That was the last question from the people here, Dr. Jas.
Sir, excuse me, last one.
Go ahead.
A controversy came that if the TPO receptor agonist is given, so in one presentation in Patna, one of the learned speaker spoke that if the platelet count is more than 250,000, you should not use romiplostin. It should be stopped. But in this presentation, it came that 5 lakhs should be cut off to stop the romiplostin. So what is your final comment, sir, in this regard?
Yeah, Dr. Priyanka, go ahead.
So, sir, I think I never mentioned that 5 lakh is the cutoff to decrease romiplostin. Once the patient responds, we gradually can increase the duration interval between the 2 doses. If it is more than 2.5 lakh, we can stop for a certain period of time, and then we can give it at a later date, say 2 weekly or 3 weekly, and then gradually stop romiplostin.
Okay, thank you.
Thank you, Dr. Jha, for that question. And just to sum up exactly what Priyanka has done. Priyanka, when people read that you are going to present on ITP, there were questions that why one more webinar on ITP? So you have silenced all of them. You have presented something which was unique. Many ITP webinars had not even 10% the contents that you have covered today. You really updated us. Fantastic understanding of the subject. Before you can sort of put it forward, you must have spent a lot of time mastering this subject and then come and present it to all the guys who are present here and are listening to you. You handled all the questions so beautifully and so aptly. Speaks volumes about your depth of knowledge, understanding, and experience. So grateful to you for sparing your Sunday morning and all the homework that you did to prepare this talk. Everybody has benefited, whether from India or anywhere other part of the world. Thank you so much.
Thank you so much, sir, for giving me this opportunity. Again, thanks a lot, sir.
Bye.
Thanks.
Thank you, sir.
Thank you, sir.
Thank you.
Bye, everybody. Have a wonderful time with your families.
Thank you, sir.
Thank you, sir. And